3, here we go. So as again, remember, you do have those 50 NCLEX questions that are due, and we're going to be going over these adaptations for children in hospitals and healthcare, and it really is different than the adult world. When you look at adults when they go in the hospital, their needs are different, and their attitudes, the way they feel about it, and how we approach them versus the children. So let's go into a lot of that little differences here. I took this PowerPoint and I put a bunch of different pictures in it. I think that the one thing I know is pictures really tell you 1,000 words, just by looking. So when I get pictures, I make sure that they're going to reflect what I'm trying for that slide to describe. I mean, look at this kid here. What do you see with him? He's got a central line in, doesn't he? And it looks probably more not like a central line, but maybe a port where they access it now and then, because I can see that it's not the normal tubing. So this kid had some sort of abdominal surgery and is going to require something for a period of time. That's why they've got that port in for that child. Okay, first thing, going into the hospital, consent. One of the things is, do we need a consent in emergency to take care of a child if we don't have a mother around? Well, no. If there's an emergency going on, you can, okay, go ahead. My grandson, of course. We're having an emergency going on, and you need to treat that child. A physician's signature, 2 physicians say that, okay, and then get that consent as soon as possible. The one question that NCLEX loves, or HESI loves to talk about, is that child who's 18 years old. Now, in pediatrics, 18 is a legal adult. So if they're alert oriented, cognitively aware, they sign their own information. But where it becomes tricky is when mom and dad want that information. You can't give the information to mom and dad. You got to have that child say it's okay for mom and dad to get it. So that child has to say, give permission. So it's a little different and a little tricky. And sometimes, those children don't want that information said. So you're caught in the middle. IDs are really important. I mean, look at how do we give medications? You need an ID band. You don't have an ID band on a patient and you need to give them a treatment, medication, you must get an ID band put on them before you do anything, okay? So get it validated, whoever makes them, get it made and get them on it and put that on that person. Because remember, they're not room numbers. We're not going to ask them their names. We need it verified and we need that ID bracelet. Years ago, we didn't worry about this as much, believe it or not. And many medication errors were made. So today we're strict, and there's many of the nurses do these weekly or monthly checks going around rooms checking, are the ID bracelets on everybody? I mean, they even do it when I was working in the emergency room to make sure, because it is so important. Safety will always be important. Always make sure if you're with a child with a crib that, don't turn your back. They will roll out. They will roll on the floor. I've seen premature children roll out of isolates on the floor. Nurse turned around to get a scale ready, turned back, the kid was on the floor. And this is a 3-pound baby. So it can happen even at that age. Always make sure that the side rails are up. There's all sorts of neat, different cribs today. Toddlers climb, right? And they're going to climb out of cribs. And you can't always be watching them. And parents don't always stay. So make sure that you pick the appropriate crib. They even have these ones that the plastic comes down now, up and down. They're getting really creative and inventive. This one here is the one basically I used a lot of my career, and we always kept the plastic down so they can't get out. Now, another thing you don't think about Because we like that bed, that crib pushed in right where it should be, right? In the room, that's where the oxygen and suction and whatever air, etc., are there. And sometimes there's the aerosols or an bamboo bag or whatnot hanging on the wall. Make sure those kids can't get into it. So pull that crib out a little bit so their hands can't go through, they can't get into electrical outlets, etc. So safety, safety, safety. When you're given medications, make sure that you go in, you give it, you don't let it sit there, don't let the kids try to get in those sort of things. And kids, yes, they love to play, and sometimes kids come in with toys and some don't, depending, could be an emergency, they don't got something. Don't go running into another child's room and getting a toy and bring it in. Make sure that it is cleaned first. you know there's playrooms usually in pediatrics. They clean those things regularly, but make sure that we are keeping those germs, because those kids, they're not completely, their immune system, especially the young ones, they're not built up yet. We don't want to give them anything. And of course, if you have oxygen going in your room, make sure we have precautions regarding those things, because oxygen is combustible. Now, in the hallway, you usually see wheelchairs, stretchers, and all of those stuff sitting at the end of the hall, waiting for a child that needs to go to X-ray or go to OR or whatever. Make sure those kids aren't playing with them. I mean, they love to get into anything and play with anything. We know that, right? I know that kids love to be wheeled to places in really neat stuff, and many pediatric hospitals have it. Always use the strap, okay? Make sure that they're safe and they can't just climb out. Never leave a kid unattended. Don't ever prop a bottle because they could choke on it. And if you have a kid who is playing in the floor or whatever around the room, don't leave them alone. They can get into things and they can hurt themselves. Again, safety, safety, safety. So the transporting, I think it's pretty neat to put a kid in a wagon, or maybe mom's the younger kid holding the babies. But when they use these little kid-like transportation device, kids love it. But again, as I said, keep them safe. All right. Make sure that they are strapped in and that it is appropriate for that child. Again, always make sure there's an ID bracelet on those kids before they go anywhere, and document. Kid went to X-ray this time in a wheelchair via transporter. Okay. Kids are different. They require different things. And that children don't respond like adults, and adults don't respond like children. So don't assume. Kids are all different. They all respond differently. Doing an infant assessment. Well, number one, in adults, you do what? Head to toe. You cannot do that with kids. Now, if a baby is asleep in a mother's arms, you can listen to the respirations and the lungs, and you can listen to heart sounds. But if they're awake, you might just fontanelle and look at neurostatus and maybe take a pulse um, um, uh, with, doing a brachial or something, looking for it. But doing an apical on a young kid moving around, going to be hard. So sometimes you have to calm the kid down. And part of my dissertation was having kids being held in the laps of parents. And I found that it's called Huggies is the thing that I made. H period, U period, G period, etc. Help us give great injections efficiently and safely. And what I proposed is children that were held before, during, and after injections, or things, that you do to them, that there was less crying, less fear, less stress. And we saw they barely cried because they were in mother's arms. So put that child in that mother or father's arms. And they usually do a lot better there. Don't try to sit them on a stretcher by themselves. It's not going to work. They're going to get upset. Again, that pacifier, soother, self-comforter, right? And always use the parents, especially with children. They want to help. Okay, they want to be a part of it. So as we look at children and doing our assessment and looking, again, you can look and see, does a kid look well? If you look at the kid on the left, look at the grimace on his face, like, I don't feel too good, right? And if you look at the girl on the right, she's sitting up, she's smiling, she's happy, she looks good. So sick appearing and well appearing, very easy, right? Also, are they small? Are they tall? Are they um, doing all the things you're supposed to be doing developmentally? You know, an 8-month-old, are they sitting up unsupported? Or does mommy have to hold them? I mean, you can tell so much just by looking at it. And another thing is looking at the child with the mother in the environment. You know, kids that are upset, you know, and we go through those stages of stressors of hospitalization, we know that some kids are upset and they're cry and scream. And then all of a sudden, you know, mom has to go. And when they come back, they don't even really want them. And they become very withdrawn. And that's appropriate. It's their way of dealing with their stress. Now, looking for things like pain, I mean, if you're sitting there banging your head or rubbing your head or rubbing your eyes or rubbing your nose, you know, that's the area, the location of the pain or what's upset, right? Or is the kid, you know, not moving because you're in so much pain, right? They're rigid. Now, looking at a kid, skin, does it look good? Is there any cuts, bruises, et cetera, et cetera? I mean, if you look at the picture there, and we're showing you pictures of, it's what we call cupping. It's a cultural thing, and it helps with pain, right? So before we assume the kid's been beat up and bruised by these circular things, make sure we ask. And also, is the kid clean? Now, all kids don't come in freshly bathed into the hospital and there's emergencies. They're out playing. But just look at the overall general. Now, history. History is important. We need to know all about the child as much as we can. We need to know medicines. Over the counter, also herbal are important. I mean, remember, all cultures have their own different things, and we know medicines and herbs can affect, you know, medicine. So we need to know what they are. We need to know, is a kid normally healthy or are they sick? How are they eating? What do they like to eat? How often do they eat? Or are they a finicky eater? They sleep. What time do they go to bed? What time they wake up? Do they go to the bathroom by themselves? I mean, toddlers, that's important to know so that you can continue those things. And what do they like to do during the day? Because remember, especially toddlers, preschool, they love routines. They like to do the same thing, same time every day. It's a feeling of comfort. It's they know what to expect, so they're not upset, right? And also, especially those younger kids, what are certain things they do that tells you that they want something? I mean, I have my grandson. My daughter taught the kid how to do this. And I'm like, what does this stuff mean? And then all it meant was, I want more, give me more. Well, I didn't know that. So my daughter taught me. And you'll see that with parents too. Again, that head to toe is not a real head to toe. It's as you get it sort of assessment, looking at them, looking at, are they breathing well? Are they breathing fast? What's their color? Are they sleepy? Are they active? Are they vocal? Are they quiet? Are they crying? All of that stuff is important to look at. And then you could take the normal stuff, the temperature, weight, blood pressure, pulse, respiration, hydration, etc. And you know, that basically is your survey, knowing what's going on. And of course, always look at maybe that thing that they came in for. Did they come in because of the ears? Did they come in because of the throat? I would spend special attention there. Now, most common sites to take your pulse is radial, temporal, mandibular, femoral, and carotid. You can take them there, all the places. But in children, it is recommended to do an apical pulse until they're about 5 years old. It's more accurate. And then radial pulse over 5 years old, okay? There's always been questions, what is the best? Well, that actually is. Remember, respirations, they're all irregular. So look at them. Are they deep? Are they shallow? Are they noisy? What do you hear there? Remember, with vital signs, things do affect what your vital signs look like. Now, for instance, this says here, if you have a temperature, your heart rate's going to be higher. But what if you're dehydrated? Same thing, right? Or what if you're stressed, anxious, nervous? All of those things can elevate your heart rate. So be aware that elevated heart rates does put a demand on the body, especially those children who might be critically ill, okay? And as I said, with infants, you can get those respirations and that apical first because they're quiet. Do that first. Now, in pediatrics, there's all different sizes of blood pressure cuffs. Do you see that one on that little premature baby there? That's the size 00. And it goes all the way up to extra large adult, right? There's so many of them. And as you are, admitting children and taking a blood pressure, you have to think, what size blood pressure cuff is going to be right? I mean, in children, you have to think that about everything, whatever you do, what's the right size for that age children? Electronic blood pressure machines are used across the board. It used to be only the pump up one stethoscope sort of thing, but they're finding that those electronics, they work really good. We know their blood pressures are lower. I mean, they're born. What's an newborn infant's blood pressure? It's 60/40. That's normal. And then a low adult would be 90/60. That's a really low adult. So 120/80 is your normal. So can you see the difference? As you get bigger, blood pressure comes up and heart rate, respirations come down. And that's the difference between adults and your children with vital signs. I absolutely like to take the blood pressure on their lower legs, especially toddlers, preschoolers, because on the arm, it hurts me and it hurts them too. And they're not going to sit still and I'm not going to get an accurate blood pressure. So I put it over their calves and I hold it and I distract them. And guess what? I get a good blood pressure first time. So it depends on what you want and how important that blood pressure is too. And absolutely, if a infant's crying, moving, thrashing, guess what? It's not going to be accurate. So trying to get these kids calm, cool, collective does help because you get more accuracy with your numbers. Now, why do we use Tylenol, antipyretics, ibuprofen? Well, number one, and the real reason is because you feel icky when you have a high temperature. You don't feel good. It is not to prevent anything. Many nurses think you give Tylenol and Motrin because if you let them with a fever, they're going to have seizures or something, right? That is so rare. I've never seen, and I've seen temperatures 106.4, no seizures. Do you know when you get the seizure? When you go from no temperature, get it like 99, and all of a sudden, 20 minutes later, it's 101. That temperature went up so quick, that's when you have your seizures. So, temperatures, what do? Well, they burn up fluid in the body, they elevate the heart rate, it increases demands on your body. So, yes, we bring it down, but most of all, for that child to feel better. And when a kid's temperature is down, they're going to drink and they're going to eat and they're going to be almost normal until that temperature goes back up, and then they're going to sit in the corner again. But again, did you hear what I said? They eat, they drink, and drinking for temperatures is important because you're losing so much fluid, right, with the temperature. So hyperthermia is not what the core temperature is really, really high. All right. Now, this is due to be sitting in a car seat in the heat and was locked in and there with high temperatures. This isn't a temperature from a disease, okay? There's a difference. This one will not respond to Tylenol or Motrin. This one, you need to put them on a cooling machine, okay? There's a difference. When you have a fever with a temperature and when you have a temperature due to you were in a fire, you were in the car, it was hot, you were locked in, you're 105, that's hyperthermia, okay? So that's a difference there. And there's some pictures of some cooling stuff. The bigger kids, there's blankets, there's a machine. It also has a temperature probe. Many times on the older kids, they'll do it rectally. Younger kids, they really don't like to, put it rectally because they don't want to, tear the rectum at all. If you see this little baby, they're just wrapped in this little cooling device, and it goes to a machine again, and it regulates your temperature. All right, so then we're talking about temperatures. How do you measure them? Well, we have oral, axillary, tympanic, and temporal and rectal, okay? And there's all different machines. When the first ear machines came out, they weren't really that accurate. But today, it doesn't matter which one you want to use. Any temperature device works. And what I always do, if I'm concerned or I don't think it's a correct one, I'll take it with another device in another area. Okay, so maybe I did the ear, then maybe I'll do an axillary. And that's what I'll do to compare. Now, pain scales. Well, back in the early 2000s, the Joint Commission says that we weren't measuring pain good enough, and especially on children. And children weren't getting the medicines and the relief that they should get. And it wasn't documented anywhere. So they came out with pain, and this is globally through children and adults, that it is the fifth vital sign. Every time you take a set of vital signs, and if any of you are nursing assistants, you take vital signs, you're going to say, so what's your pain level? And you write it down and you go to the next patient. So when you when you first start doing vital sign, pain scales from newborn to 3, it is FLAC. And FLAC is also nonverbal children. And what it does, it looks at the face. Are they grimacing? Do they got the quivering chin? They look at the legs. Are they moving and thrashing, right? And they're like sitting there and you can see something's wrong. Their activity, are they crying? And then can you pick them up and console these children from 0 to 3? Because they say that they really can't tell you how they feel until after 3. Well, then miraculously, after 3, they use the FACES scale. And it breaks my heart when a little boy of 4 years old points to number 8 and says that's what they heard. And you see this little sad face. And you could tell children don't lie. When they give you a pain level, it is the level they tell you. Now, weight. I say it every class about weight and height and children. This is something we do every visit, every doctor's visit, every urgent care, every ER visit. We do a height and a weight. We do it, number 1, to monitor nutrition, if they're eating right and growing properly. But number 2, and most importantly in these areas, is if we need to give medications, we're giving accurate doses. Now, your BSA is your most accurate way of getting a dose, but the weight is what we use across the board in pediatrics. It's just what it is. When we're measuring the height on children, well, babies, you sometimes we'll just take and put them on the bed and we'll put a little mark on top of their head, pull their foot down and do the bottom and then measure it with a tape. It's easy just like that instead of trying to put the tape across the whole baby as they're trying to wiggle. So that's what that one is there. I like it how they put it against something solid so they know they're getting a good accurate height. And as they get older, we could take the thing that comes down on their head. Now be careful. Some 2 and 3-year-olds think that thing is going to come down, bop them and hurt them. So make sure you're explaining what you're doing and let them put it there and say, okay, it's on the top now. So now they know that you're not hurting them, okay? Big deal with kids. I worked ER a lot and I did a lot of height and weights and a lot of children. And some of them wouldn't get on that thing that came down. They were just definitely afraid of it. Infants were always measuring their heads. We're concerned about things like hydrocephalus, right? Or water on the brain. So we do it if you see it right across the forehead and you can above the eyebrows, above the ear, and it circle around. And usually it's done every shift with if you're working in a baby nursery, newborn ICU, or PD ICU if they have a baby there, okay? Very important to monitor. If it gets, gaining too many centimeters, because we do it in centimeters, something's wrong. It needs to be investigated. Now, getting specimens on children. Number one, make sure that always, because we have a lot of times we'll get a urine specimen, a urine catheterized specimen. We'll forget to label it and we'll send it to the lab. And this mother already had a hard time on this 3-month-old that we had to get this urine specimen on, and we didn't label it, and we didn't send anything with it. Guess what? That lab is going to throw it out. And guess what? You're going to have to do that specimen again. And that mother is not going to be happy with you. So make sure you have the lab specimens, the correct containers, clearly labeled, put the forms, and then put it in those biohazard bags the way you're supposed to. And especially on younger kids, make sure that we document and take an output. I mean, if they have 30 cc's out, that's something that we need to document. We can do all sorts of specimens on children. The urine cath on the young child is the most accurate and best thing to do, especially if we're worried about urinary tract infections, because we don't want to have to put this kid on multiple types of antibiotics. We want to put it one and done. And we only know that by getting an accurate specimen, sending it for culture sensitivity, and it tells us, okay, good, the antibiotic we put them on is working, because we don't want that kid to have to get an infection again, because they don't have an immune system, remember, especially those young children. Cerebral spinal fluid, again, make sure that's labeled. I saw one case in my career that they lost it. It wasn't labeled, and they had to go back and do it again. And telling a parent that is not a nice thing at all. Make sure that you always follow protocol. If it says it has to be in one of those biohazard bags or carried over to the lab, make sure you do what you're supposed to do in order to get those specimens done correctly. And the one thing, we think we can do is in newborn ICU, we do urine glucose every shift. And we do it by the diaper and put it in a syringe and get a drop of urine, right? Well, we can't take that diaper and squeeze it out and get a urine specimen on it because it has all this other stuff in it. It's only good for that one little test that it's done every shift. Now, children. Children and old adults, it's both ends of the spectrums, actually. Infants respond differently than younger children or older children, they all respond differently to medications. Remember, they don't metabolize or excrete things as quick. The way that their body handles it, we have to be very careful for safe doses. Okay, making sure that we're not giving them too much and to look out for those sort of reactions that can handle. I mean, many times children have never gotten an antibiotic before, and sometimes you give the first dose ever. What you're going to be worried about is things like anaphylaxis, okay? So always know that these kids are sensitive and to be extra, extra careful. When they get to the stomach, they don't absorb as quick. Remember, their intestines are not mature yet, right? Especially the younger kids, younger than 6 months. So maybe that oral medicine goes out quicker. They may not get the full results. Be careful, careful, careful on applying topical medications. I saw one little boy. He was 8, maybe, but he was a tiny little thing. Came into the ER, sort of had this blank stare, looking to the side, and had this rash over his body. And he came in with his father, and he wasn't responsive. He was walking, but not responsive. I said, "So, Dad, what's going on?" He says, "Well, he got a rash. So I took Benadryl ointment, cream, whatever it was, and lathered up this rash all over his body." But then he gave Benadryl orally. This kid was overdosed on Benadryl. And just by putting it topically, you can get overdosed. So making sure we don't use too much. They say with ointments, creams, littler is better than more because of those sort of reactions on them. And remember, parenteral, once it's in, it's in. So you have to administer very carefully. As I said, metabolism, excretion, this is the way that it gets into the body. Remember, their liver is a little slower. It's not going to get there as quick. So again, lower doses further apart might need to be needed because we don't want to keep giving doses and it's not metabolized and it's not excreted. Very important that we look at those things. And if those medications have lab values like peak and trough, make sure that we do them so that we save the kids' eyes, their ears, and their kidneys. As I said, most, of course, all medications rely on the kidney for it to come out. It's metabolized, it's used, and then what's left is gone and it's excreted. Their kidney function is still really, really decreased, especially in children less than 1 year old. So you've got kidneys that are slower, you've got the liver that's slower, you've got the stomach that's it's slower than getting the medicine out. And then you've got that GI tract doesn't absorb straight through, right? So all of these things make this child at risk for toxicity. So being aware of side effects, very important. So always, when you're looking at kids, they can have immediate reactions or it could be on the last dose. That's what makes them special also. So, I mean, if it's a kid, a rash, well, that's easy to see. But sometimes it might start out with like a cough. And that's starting with the throat closing. And you don't think about that. But that could be the sign of, wait, I better get some epinephrine here. Something's happening. Let me tell somebody what's going on here. So always, always, when you give medicine to children, make sure that you calculate your doses yourself and that you administer it safely. So parent teaching, I use parents as my second hands in a hospital, always have. They have to go home with the parent in the end, right? So they need to know what's going on, what to look for. I mean, I don't have to be doing everything. And as they're in the hospital, I'm teaching them. So always teaching them how, like, for instance, medications. how to administer it. And again, sometimes some children are hard to get every dose of medication in. And by the sixth day, you're like over it. It's only one more day. I'm done. I'm not going to give any more. It is important with medications to complete the whole cycle. If it's for 7 days, make sure that they do it and explain some of the reasons why it could happen. That other stuff could happen if they don't treat it, especially strep. Strep is a big one. You make sure that they do. Make sure they know how to measure it. Make sure they know how each dose, how frequent it's being given. And then, of course, always trying to get that kid to do what he's supposed to do, that compliance, and always have a schedule. I teach parents to take a piece of paper, put it next to the medicines, and write on it when they gave stuff, because by day 3, with they're not sleeping because the kid's sick, he was sick 3 days before he got in, they're exhausted, they're working, there's other family. Write it down, and then you're going to decrease the amount of errors. So oral is always preferred. We prefer to give everything if we can orally. Now, we do have nose drops, ear drops, eye drops. They're not as bad, to give children. I mean, eyes sometimes they get a little frustrated with. Rectally, many times this is that kid who don't like medicines. Mom will say, all right, they don't like medicine, he's got a fever, and they go ahead with a Tylenol suppository. They think it's easier, but remember, we worry about rectal tears, right? And of course, if we can prevent needles, those injections, we would prefer not to give them if we didn't have to. Now, medications, and you have children like the first picture in this chapter. We're looking at parenteral and long-term ones. Now, if you look at that picture up there, that's a Broviac. And I know that because it's white and it's just got the look of it. Now that is going to stay with the thing outside. The one on that first page had a little thin, more of a clear tubing. And that's the tubing that we do for a port, which means when that kid goes home, we take out all that sticker and all the stuff from top, and all is left with skin because it's underneath the skin, the port. And then an RN will access it, and then we'll have that IV. This one is a Broviac. This will always be hanging out. So if a kid needs to go home with this sort of thing, we need to teach them how to keep it safe and from pulling, because they can pull these things out. And that goes directly into the heart. Another type of IV, used quite frequently now, is called a PICC line, or a peripherally inserted central cath. Usually it goes through the arm and it goes up. It's very thin and it goes into the heart. And usually these are used for those children who need to have long-term antibiotics, especially when they go home. And just a little bit will be sticking out. But again, remember always to keep these things secure. Make sure that, there's something that holds it to the body so the kid can't pull and rip at them. Because, give it to a 2-year-old, they're going to play with it. A 1-year-old, right? And we don't want to have to get them put in again. Now, giving medications, the other thing is, how much can I give and where do I give it, right? So IM injections. Now, infants is only 0.5 ml. Now, this is what we talk less than 1. Actually, even like, I would even say younger than that, because if they're a little older, a little pudgier, they might get 1 ml in there. But generally, per the book, it's 0.5 ml. Toddlers, you can get 1, and usually these are vastus lataris that we're giving them, okay? Until they got really, they're up and walking and running well, those muscles in the back and the buttocks and ventrogluteal are not good enough. They don't have enough room to get that IM injection. Now, school-age adolescents, you can give some IM injections in the deltoid, but usually they'll say put them ventrolateral. That's because they usually give what as an IM? It's usually antibiotics, right? Or maybe a steroid when you're not breathing well, and they burn, and you don't want them in the arm. You want them in the deep muscles of the buttocks, okay? So deltoid, um, just simple little things we can put there, but vastus lataris for children, we can give older kids up to 2 mLs. As I said, IV is directly in. Now, I found some really good pictures of some infiltrates. That one to the left, that's really a common looking picture sometimes. Looks like the hand was on a board and it did get quite swollen. So what's the first thing you do when you think an IV is infiltrated? You turn it off. Turn it off. Stop it. If you think it is, stop it when in doubt. And then many times you put so much tape and stuff on, you can't see down there, right? So as you know, as a nurse, and I'm a very good IV starter on even very difficult children and adults, I would make sure that I could see the site where that IV was and seeing what's happening. And if I saw leaking or redness or I saw fingers getting puffy, I'm going to take everything down and look at it really, really close. Another thing is some medications you need to tell the doctor before you pull out the IV. Sometimes there's like these little antidote type things that we need to put through that catheter that the doctor will do, okay? So it will help with circulation. So always ask first, should I remove that IV? INO is so important. Always with IVs, you're going to be checking that site every hour. You're not only going to check the site, you're going to check the pump. You're going to see what's still in the bag. All of these things you're going to look at for safety for that child. And of course, monitoring intake output, making sure children can go into congestive failure really quick. So we want to make sure the output and the input are really close. So a kid getting IV fluids, and they need to get an IV. I mean, I worked in the ER for the last 10 years of my life. And before that, I did 10 years in the cardiac ICU. And you have to put IVs in all the time, right? It's because it's getting children better. So I would talk to the kid, tell him what was going on, what I was going to do. I use all the numbing stuff I possibly could, and I would tell them what it would feel like. And then I would distract that child by the parent showing them a picture, iPad, blowing bubbles, playing with stickers, whatever it was. And I could get that IV in. And then, I would even ask the child, where do you want it? This arm, that arm, older kids. If you get them involved, they're not going to be as afraid, and letting them know if it's going to hurt or not. Now, if you're putting an IV in and you've used numbing stuff, usually you feel touch and no pain. Okay, so always be honest if it's going to hurt, because then they'll never believe you if you hurt them, right? I don't like to hurt kids. Medication safety, always, doesn't matter, adults, children, patient dose, time, route, and you need to document it. And always document it as soon as you give it. Calculating those doses, I said BSA is the most accurate, but we do use milligrams, micrograms per kilogram as part of the practice today. I've never seen a BSA used in my career in pediatrics, but I guess if we had to do something really the most accurate for whatever reason, it would be done. And then this dimensional analysis, I don't know how to use that. I have my own way, and I've shared that all with all of you. Here it is. If you want to look at it, I just use the dose over what I have times the quantity it comes in over 1, and I figure out a dose for anything. Way to think about IVs is, where am I going to put it? Now, if the kid likes to suck on his right thumb, are you going to put it in the right hand? No. Um, if you have a kid who kicks a lot, are you going to put it there? No. So you really need to take some thinking. Where is the best place for this kid? How would it be best for this child? Again, if you can get the kid ready, always have a parent involved. Let them know and let them listen to the way you're describing the children. Remember, kids do better with mommy and daddy there. Without them, they're scared. My mommy, my daddy's not here. And that's all they're thinking about, and they're not listening to you. And then once you get that IV in, protect it. Now, that little thing on the bottom, that little plastic thing is called a house. This is what they call it, an IV house. And it does protect it. I've seen styrofoam cups sometimes put over it. This kid up here in the crib, if you look, they have elbow restraints on, so the kid doesn't touch the IV. Whatever you need to do to keep the IV in, we don't want to have to keep resticking these kids. Now, preventing drug interactions, there's so many things that are done today to be careful of. I know working in an ER, there was all sorts of warnings. You want to give this one antibiotic, they can't be on a Ringer's IV. And you have to say, no, they're not on it. There's clicks you have to do. When you have medications that are given on the unit, whether on the floor or intensive cares, it goes through the pharmacy and it comes with warnings. And you'll see those warnings there on your MARs and usually on the medications. There are medications, for instance, nitroglycerin. You can't have it in the sunlight. It has to have foil wrapped around all of the tubings. It's just one of them. Dilantin and acid can't be given together. And iron and egg yolks, because the egg yolks stop the effectiveness of iron. In fact, you're supposed to give orange juice with it. It enhances the iron going in. Now, cavage feeding, very, very common in the young infant. And I mean, I've seen 2 mLs given, every 3 hours, and you build it up from there. And remember, if these kids, infants, need to have an NG tube for whatever reason for feeding. Now, remember, there's an NG tube through the nose, and then there's OG tube through the mouth. Many times we will put it down the mouth, into the stomach, and we'll just tape it to the side a little bit. Remember that to give them something for growth and development, give them a pacifier. It is normal to suck, swallow, and breathe, right? So giving them the tube feeding, have them do the same things. And remember, don't get that pushed down quick because it goes directly in the stomach and it gets big and that infant will vomit on you. So take your time with it. Now, gastrostomy tubes are right into the stomach. There's different types. I put the picture on the right. That thing will come off and it's called a little button or a mick or a Mickey. The one on the other side, you'll have stuff hanging out again that you're going to have to secure, usually with mesh they put around there, or they put a nice tight t-shirt on these children, to hold it in there. Remember that this can give medications, can give food. It's for those children who need extra nutrition, who can't eat it, or they have the inability to swallow. And there's many sorts of diagnoses where they can't swallow. Pierre Robin, DeGeorge syndrome, both, they have a difficulty with that. And it takes a long time with speech and occupational therapy to do that. And then sometimes we can use these things and looking at whatever the residual is in there, knowing what that residual should look like. Now, children, especially that toddler age, and the preschooler, the only thing they can control is their bowels, believe it or not. And I have seen children go 7 to 10 days without having a BM. And if you look at that x-ray, all that white, that is a stool in that poor child's belly. I can't imagine how that might hurt, right? So They come in, they haven't had a bowel movement because maybe they're stressed, something's going on, or maybe it's just a physiologic thing that they have a trouble with it. But many times, emotionally, they can hold their stool. Why they do that? It's just to get attention sometimes. But what we'll do is a little Fleet's enema. You put them on their side, and it's smaller than the adult, and you put it in, put an extra big diaper on because you're going to see an extra large bowel movement come out. So never just water. Use a Fleets. It is the best for a constipation to get rid of that. Now, suctioning. Suctioning the nose is done for all different reasons. Well, many of you do have infants or have seen them where they get this mucus and boogers in their nose, and you need to get it out, and they can't blow their nose, can they? So you need to get rid of it. So what they'll do is, if they're in a hospital, they'll take and they'll put a suction little bulb nose and suction it out, and it clears the airway. The thing with suctioning the nose, especially when they have all this built up mucus, whether it's RSV or whether it's upper respiratory, is if you over suction, it stimulates more mucus. So you will do it right before they eat to make sure it's clean, okay? Now, sometimes with suctioning, it can cause a lot of problems. So you have to be careful and not, especially use that long, thin catheter, making sure that we don't keep it down there too long. I think the book says up to 15 seconds you can suction down once and out. Now, things to look for in the respirations. Well, remember, respirations is oxygen, and oxygen is what you need to be alert and oriented, right? So if you're having issues breathing, you're not getting oxygen and you're going to become restless. That's one of the big symptoms of hypoxemia. Doesn't matter, kids or adults. Hypoxemia, it's restless. Then the body wants to try to compensate for that lack of oxygen from whatever reason it's lacking. Heart rate goes up, and then you're going to see them dyspneic and retract, and their colors get pale. Their peripheral perfusion goes way down, and then you might see cyanotic areas or circumoral. You will see these sort of things going on. Now, what happens if a kid is eating something and it sticks in there? According to CPR, what do? Well, you want to thrust it hard enough to get it out on the older kids, right? But as I said, don't off their feet. And that's like a modified Heimlich on adults, but it's called abdominal thrust on children. And then infants, it's the fingers, like you're doing CPR, but you're downward thrust on these children, and it does, and it will come back, or you do the back pat. All right, going into the OR. Years ago, we used to make the parents not go in the OR. They couldn't even go into the waiting room. And these poor children would be there crying before surgery, so they're not in a good state of mind. And they learned, it's better. Let's have mom and dad come in, or one of them, or if you allow both, depending, go in and stay with the child and keep them comfortable. And they even learned to bring them into the OR room. They're doing that now, where they put them to sleep. And once they're asleep, the parents leave. So now they know, the parents, that the kid went to sleep, he's comfortable, he's, going under surgery, and they feel good, like they've done something. Children should be prepared. They should know what's going on. They should have, dolls and equipment to see what does an IV look like, or maybe a tube's going to come out of them somewhere. They need to understand those. So teaching is so important. That is that psychological preparation. What are they going to see or feel? Everybody's dressed in green with hats on and masks, right? That could be scary for a kid. Kids should never be held NPO more than 4 to 6 hours. And infants, they usually say breast milk up to 2 hours before. And if they can't eat, especially young children, give them a pacifier. Because why? What does the pacifier do? Self-soothes, makes them feel better, okay? And, post-operatively, the kids come out, make sure that their pain has been addressed, that they're comforted, they know where they are. And as soon as we can, we get the parents in there to help them also today. So a lot of big changes in even the OR recovery. Any questions?
For our exam,
Yes.
are we gonna have the kilograms and the stuff to convert it?
Milligrams per kilogram?
Yeah, per
It's
day.
probably.
Oh,
Probably. Now, have you listened to my recording? And have you looked at the worksheet? It's very simple. Where is she? Monet. Tell her how to do milligrams per kilogram. I worked with her earlier today. Just multiply, right?
yes.
Make sure you put it in a kilogram and multiply it. That's it. That's your dose. All right, and it's nothing more than that. Now, I did give you dosage calculation things. The shorter one is specific for the PN program. So it's what, 40 minutes, 30 minutes. Look at it. It will help you. And the questions I even put in the handout is very similar to what you see on the exams. I can't give it to you more than that. It's there. Different numbers, different type of medications, but it's there. You have it. Just got to look. Okay. I give you all the tools to succeed. You just got to use them. All right, let's go to do our Cahoots. I had ear tubes put in yesterday. Can you imagine at my age? And it's draining, and that's what's going on today with me. What am I going to do with myself? I walked in, the doctor looked at me and said, Betty, you need tubes. I said, I know. That's why my husband's here. Got dizzy as dizzy can be. Done at the doctor's office. And they do it in the OR for children, right? So we will be getting out a little bit earlier today. I've done the best I can. It's not a great long Cahoots. I believe there's 20 questions, but they're good ones. And a lot of concepts that you're going to see on Cahoots, you're going to see them on exams. So always go back and review the Cahoots I send you, okay? I spend time doing them, making sure you have everything you need. And again, use what I give you. That's why I give it to you. I take time doing it for you. And if you need help, ask me. I will meet with you and I will show you how to do dosage calc easy. Week 3, chapter 22. After instilling nose drops, the nurse will keep the infant in the head down position for at least what? Do you remember your pharmacology? Now, when I give you Cahoots, sometimes I don't have it in the PowerPoint. It's hard to put everything in one place. So you'll see it in both places, okay? So 30 seconds to a minute is where they should have you there, believe it or not. Before that, it doesn't go down and get to where it needs to go. I was shocked when I saw that because I actually didn't know that answer. When planning care for a toddler, what behaviors do we need to consider to promote security? How do you get a toddler secure in a hospital? Think about toddlers. Me, mine, me do, no, no, no. And it's all about routine. Remember I said, when do they take their baths? When do they take their naps? When do they eat? Ritualism, it means rituals, which means routine, routine, especially toddlers. According to Maslow, what level of hierarchy of needs correlate with the measuring of vital signs in O2 sat? You're going to have some questions on Maslow on your exam. So knowing that it goes from your esteem down to basic needs, okay? This is the hierarchy. And you need all those things to be a person, Maslow. So those are things you can measure that you have. Those are physiologic needs. That's your first step in Maslow, okay? A child explains that the nurse that he got sick because he went swimming in the rain, according to Piaget. Now, this is what level of understanding? Remember, when you talk understanding, you're talking Piaget for sure. All right, understanding. I was in the rain, I went swimming in the rain, and I got sick. That is now what we call concrete operational. This is school age. They're starting to realize what they did wrong, which caused something. They're getting smarter, putting two to two together. Very important concept that I just gave you right there. Gentamicin eardrops are prescribed for a 4-year-old child. How would the nurse position the auricle? Is it up, down, back, in, out, over, under? Which way does it go? And I used to teach pharmacology. It is up and back. Okay. Down and back is when? Older, right? Up and back. What is the best pulse location for the nurse to use when assessing the pulse rate on a 12-month-old infant? I need a heart rate. How am I going to take it? What's most accurate? The best location. And it's apical till they're 5 years old, right? Very good, guys. A 4-year-old child asks tearfully if the IM injection will hurt. What is the nurse's most effective response? You know, this is where sometimes when the medicine goes in, it might sting a little bit. So they may not feel the sharpness of it, but yes, it will sting a little. Be honest so that when that child gets something else, they'll understand. What antibiotic is known to cause discoloration of teeth in the young children? This used to be one of the only antibiotics back in the 50s and 60s that they used all the time. It's tetracycline. And what it does, it turns them gray. And you can't get the white back. It turns them gray, something to do with the calcium or whatever. And these are young children, they say under 8. A parent tells the nurse, I'm not sure how to give this medicine to my infant. How would the nurse teach the parent? So you just take an oral syringe and a little by little you put it in the side of the mouth. Put it in the nipple, they're depending it, they may not suck it, but if you put it in a syringe, they're getting it in the mouth. They have to drink it, okay? In a cup, it's not gonna work. And a dropper, you're really not measuring it. And make sure you don't just squirt it in the back of the throat, because guess what? That kid's gonna vomit on you instantly. When should a child begin to be able to feed themselves using a spoon or fork? And this is the end of the second year. At the end of the second year is they should be able to. Now, are they using spoons earlier? Yes, probably, but effectively, probably not. Upside down, crooked, or just playing with it is usually what they do earlier than that. So the end of the second year. Should parents be concerned about how much fat they include in their young child's diet? Remember, fat's important for the central nervous system. So children up to age 2, don't worry about it. They need that fat. You shouldn't put them on skim milk, those things. No, they need the fat in their diet. What type of play are toddlers known to do? As you see, I'll go back to last week, get some other stuff, concepts I know you're going to see, and I'll throw them on these Kahoots for you. Just that re-emphasis. Toddlers are all about playing by themselves. They can play next to each other, but they're not going to play together. So it's mine, me, I'm not sharing. That's toddlers. Which restraint is most appropriate for the insertion of an intravenous line in a scalp vein on an infant? So you have an infant and you can't find any sites on the hands or whatever, or you can't. So you have to use a scalp vein. I mean, parents don't like them, but they're very easy to use. They're very easy to insert, and you can watch them really closely. But when getting it put in, especially if you have no help, you take in the mummy, which is just really wrapping them up in their blankets. And that's like the mummy restraint, and it works the best. How often should a child who has continuous IV infusion be assessed? And it's every hour it should be assessed. Because remember, if you're putting in 10, 12, and it could be just 10 or 12 mLs an hour, that's a lot for a little hand or a foot. And it could really infiltrate and get really swollen really quickly. So every hour. What type of method is most accurate way of determining the correct dose of medicine for children? Most accurate. And it is the BSA, absolutely BSA. And as I said earlier, we do use milligrams, micrograms per kilogram, but BSA is actually the most accurate. But I've never seen it used. According to Kohlberg, conventional morality, school-age children, what does that mean? School-age children, their morality, what do they feel? What do they think? And these children love to follow the rules because they like to please. They don't want to do wrong. It's the type where, let's say, all your buddies walking home from school stop at the 7-Eleven, and all of them will steal a candy bar, but you don't. Why? Because you don't want to get in trouble. You don't want to break the law because you want to do the right thing. What developmental level of Freud are school-age children developing to form relationships? So which one is which? Oral is infant, everything in the mouth. Anal is toddler, potty training. Phallic is your adolescent. And latency is your school-age children. Okay, remember those words. Why do they pick word like latency? Doesn't make any sense. I can't relate it to anything, but that is the word. That and conservation for Piaget. Which intervention will the nurse implement when suctioning a tracheostomy? Got to put that tube, that thin suction tube, down into the tracheostomy tube in the lungs and suction. You know, this is a wrong answer and a wrong question. I got them mixed up. Vastus laterus is where we give infant injections. I apologize. Adolescents are all about body image. Erickson describes this as what? And it's all about identity. Now, let's look at this question. Industry is school age. What do I do well? Inferiority, what I can't. Initiative versus guilt. That's your preschooler wanting to do good things for you. Identity, of course, adolescence. And then autonomy versus shame and doubt. Autonomy, me, my, mine. Toddler. Know those names, okay? And tracheostomies, how would you suction? You would go down to the tip of the tracheostomy tube, suction no more than 15 minutes, and you would never reuse a suction catheter, okay?
15 seconds.
15 seconds, yes. That's the longest, and that's pretty long. What is the final stage of Piaget's developmental theory where adolescence increases moral reasoning? Final stage of Piaget, adolescence. Again, knowing the words and figuring out which group hits it. Now, concrete operational school age, and then the final is adolescence, which is formal operations. And I call that they can figure out a way to do things where your mom said you couldn't do it, and they figure out what they need to do to please mom to say, all right, I took the garbage out, I made my bed, I got an A on the test, I babysitted your, baby brother. Can I go out, please, Friday night? Well, you did all that things good. Okay. They know how to make things work. They're logical. And that's it. Number 3 is Monet. Good job, Monet. Whoop, whoop, whoop. Number 2, also TH. And number 1, Garshell. Look at you again, girl. And KW and Whitney. All right, I'm letting you out early tonight because I don't feel as good as I should. So you get a break. Anybody who needs anything, let me know. If you want to go over math before the exam next week, just let me know. I'm willing to do that any time in the earlier on Friday, okay? Goodbye, everybody. Thank you so much for your patience.
Thank you. Have a good night.
My pleasure. Thank you, guys.